This presentation will be on the assessment of the head, face, neck, and the regional lymphatics. First, we'll review the structure of the head itself, reminding us that the skull is this rigid, bony box that protects the brain and all the special sense organs underneath. It also includes the bones of the cranium and the bones of the face. You notice here along the middle points and around through the skull, you have immovable joints called sutures. The coronal suture here, this is the crown. It crowns a head from ear to ear, from here all the way through, and at the union of the frontal and the parietal bones. So it's right between these two bones. The sagittal suture will separate the head lengthwise. So between the two parietal bones, it starts here and it goes down all the way to the lymphoidal suture. And this is what separates those parietal bones from the crosswise of the occipital bone. Now, the human face itself, we can make many expressions that reflect our mood, and all of these expressions are formed by that facial muscle, and it's mediated by cranial nerve 7 here. And the expressions that are formed by these facial muscles should be functioning symmetrically bilaterally, except if you are, occasionally winking your face or making a weird expression. Other than that, when you speak and when you move, your facial features should be symmetric, innervated by cranial nerve 7. There's 14 facial bones, and they articulate at the sutures as well. Think about the nasal bone, zygomatic, the maxilla, all except for the mandible, which is that lower jaw. It can move up and down sideways from this temporal mandibular joint. And this is a joint that's going to be important for us as we continue our presentation today, as you will hear more information about this, and we'll be using it as a landmark. And this joint you can find anterior to each ear. The cranium is supported by our vertebrae, C1, the atlas, C2 is called the axis, all the way down to C7. And C7 is easily felt if you put your chin to your chest and feel that bony prominence on the back of your neck. That C7 vertebrae is long. It has a long spinous process that's palpable only when your head is flexed. Well, I mean, you could feel it when it's not flexed, but it is more exaggerated when you do put your chin to your chest. This is a useful landmark. It's called the vertebral prominence, and we want to use that also to help us with our assessment today. Now, the facial structures are symmetric, so you're looking at the eyes, the ears, nose, mouth. They all should be about the same on both sides, and the palpebral fissures, which are the openings between your eyelids, they should also be equally bilateral. Palpebral fissures is another landmark that you need to be aware of. The nasal labial folds, these creases extend from your nose to each corner of your mouth, and they should be symmetric. In addition to the movement of your face, you should have equal sensation of pain and touch. These are mediated by your cranial nerve 5, and there's 3 branches of cranial 5, which is also called the trigeminal nerve. In terms of the neck, it's delimited by the base of the skull and the inferior border of the mandible just above and by the manubrium sterni, the clavicle, and the first rib. And you can see it is right there by the first thoracic vertebrae below. When you think of your neck, this is an area of passage for many of the structures. And they all lie really close in proximity. So we already talked about the carotids and the jugular veins, so our blood vessels. There's muscles, nerves, lymphatics, and viscera of the respiratory and the digestive systems as well. And your blood vessels include the common and internal carotid arteries, the associated veins, which you've seen previously in the heart and neck vessel slides. The internal carotid artery branches off the common carotid, and it's going to run inward and upward, giving the blood supply to the brain. The external carotid is providing blood flow to your face, your salivary glands, and the superficial temporal areas. So those are the areas right here on the slides, in front of your ear, at the eye level. The carotid artery and the internal jugular vein, as we've been able to palpate in recent weeks, they are going to lie just beneath that sternomastoid muscle. And the external jugular vein, it runs diagonally across that sternomastoid muscle. The major neck vessels muscles that we are going to be talking about this week are the sternomastoid and the trapezius. And you see the sternomastoid is the big one that derives from the back of your ear going down into that sternal notch. And then the trapezius starts posteriorly and connects to the clavicle area. The two trapezius muscles in the upper back will rise from your occipital bone and the vertebrae. And again, it's fanning out to that scapula and clavicular area. These are the muscles that will move the shoulder and extend and turn the head. The sternomastoid divides each side of your neck into these two triangles. We have the first one, the posterior triangle, between the trapezius and the sternomastoid. And then we have the anterior triangle that lies right below your jawline and connects one sternomastoid muscle to the other on the opposite side. The thyroid gland is an important endocrine gland that we will talk about that lies between the two sternomastoids and in this anterior triangle area. This is a highly vascular endocrine gland that synthesizes and secretes thyroxine, which we refer to as T4, and also triiodothyronide, which is T3. These are hormones that stimulate the rate of cellular metabolism. The thyroid gland itself has two lobes, and they're both conical in shape, and we usually refer to this as like a butterfly shape that branches off and thins out at the isthmus of the thyroid. And it wraps around the area in that anterior triangle zone. You will have to be able to articulate where these lymphatics are located and the names of the lymphatics, and even more importantly, the drainage pattern, which you can see on the picture above. So we have the preauricular lymph nodes, reminding ourselves that it's just not one node you're looking for, but a grouping of nodes. So we have the preauricular here at the front of the ear. Naturally behind the ear is the postauricular node, and this is superficial to that mastoid bone or mastoid process. We have the occipital nodes. They're found at the base of your skull. Then we would move into the submental, which is at your jawline, halfway between the angle and the tip of, the mandible. You're going to find now the submandibular. Okay, so we move from submental to submandibular. Then we have the jugulo-digastric. Sometimes it's also referred to as tonsillar. And these are the most common terms for this one, but it does have many different names. And you find it under the angle of the jaw, right below that ear. We have the superficial cervical and the superficial cervical. These will lie right over that upper area of the sternomastoid muscle. The deep cervical will be down here, and they cross over. There's a deep cervical chain, and it's deep under that sternomastoid muscle. So you need to palpate just a little bit deeper as well. We have the posterior cervical. Posterior, so in the back, and it's in that posterior triangle area. And lastly, we have the supraclavicular. And even though this is only showing one, it's a series of nodes that lay right above, supra meaning above, the clavicular line. You also note the drainage pattern, and you can use this image to help you to understand where things may be draining to, things meaning infection or lymph, where they would be draining into to enlarge the nodes depending on where it's derived. So if there was some type of sinus pressure, sinus infection, and you see it here at the midface, on the cheeks, by the nasal areas where your sinuses are located, then it would drain into this submandibular lymph node area. This is where, if there was an enlargement here, if your patient felt that there was an enlargement here, you would look upwards to see what drains into that area. If there was some enlargement in the submental area, commonly it's because there's maybe dental work. If there is an enlargement here in the jugulo-digastric area, it may be coming from the ear or the upper face, moving into that area. Now note, once you get here below at the supraclavicular line, it's what's below the clavicles that are draining upward now into the supraclavicular area and also parts of the deep cervical chain. So more commonly, a breast infection or breast cancer can be detected with enlarged supraclavicular nodes. So it's moving from the lower aspect of this area up into the supraclavicular. So I'm stressing this image to you because you will be tested on this and you want to be able to determine where the drainage is occurring from. And moving on to health history questions, what are some things that we might ask our patients if we were doing a focused exam? Commonly, our patients will have headaches, and we want to, in all cases, use old cart to help us determine, the onset, the location, the character, etc. How frequent, how severe. We want to know how it affects their life. Is it a mild, moderate, severe pain? How long does it usually last? Is it 1 to 2 days, 1 to 2 hours? What makes it worse? What makes it better? What were the things that you were doing when it began? What do you usually do to treat your headache? What are your coping strategies? What meds are you taking? For head injury, so being a trauma, we also want to use old cart to determine when it happened, what was the severity, what are the circumstances around it. I want to know if this patient has a history of other illnesses like heart disease, diabetes, epilepsy, which is a disease with seizure activity. I want to know the exact location where the trauma occurred. Is it painful? Dizziness, same thing. What causes this dizziness? What makes it go away? The onset of neck pain is an important one. Sometimes it is a musculoskeletal etiology, but other times it could be from some type of infection moving into that nuchal area or that neck area. And one thing that comes in mind is maybe meningitis. And a lot of times our patients will develop this nuchal rigidity or tightness in their neck. Other times, more often, happening to me quite often is, it's related to stress. A lot of us carry our stress up here in that neck area, or it could be positioning, whether you're in long car rides, the way you work at the computer, or just generally the day-to-day activity. We also want to know about their coping strategies. What do they do to alleviate this pain pressure? If it is that nuchal rigidity for meningitis or something similar, then we're asking questions about infection and things related to infection specifically. If there's any lumps or swelling, I want to know about any sick contacts. Have they been sick recently? Have they had a recent infection? Is it tender? Have there been any drastic changes in size, larger, smaller? I want to know if they've had any history of neck swelling in the past. I want to know if there has been any history of cancer, malignancy. Lumps and swelling, especially in that neck area, could put pressure in and on your esophagus. So I'm asking about difficulty swallowing. I'm also asking about difficulty eating. Do they smoke? Do they drink? Have they had a diagnosis with their thyroid? Do they have other thyroid symptoms and or thyroid problems? And then lastly, I'm asking just about their surgical history. Have they had any type of head or neck surgeries, biopsies, and of course you want to know when, where, and the outcome. We're going to move on to the objective data now and talk about what entailed in the physical exam. First, we are going to both inspect and palpate the skull. With adults, we should not be able to feel any suture lines. It should be smooth. You are putting your hands and fingers on the person's hair and scalp, and you're palpating and you're moving through the hair. You're making sure that everything is symmetric, and again, mentioning that it is smooth. There should be no tenderness to palpation. That's what TTP is. There should, in that temporal area, you want to palpate. And this, again, remember, it's right above that zygomatic bone or your cheekbone. It's between your eye and the top of your ear. And you're palpating here to see if there's any tenderness. And you shouldn't feel, any bounding sensation there. You may be able to feel pulsation, but it shouldn't be bounding. It shouldn't be torturous looking. It should be nice and smooth. And the temporomandibular joint, or the TMJ, this is an area, again, right, there's a divot right in front of the tragus of your ear, and as the person opens their mouth, you should be able to feel smooth movement. There shouldn't be any tenderness or limitation in opening the mouth. Sometimes you will feel crepitus, and crepitus is that crunchy noise, it's that crackling noise that demonstrates the movement between bones. And some people experience this very severely, and other people, you can hear it, but it doesn't really limit their ability to move or eat. A person that does have limitation in the temporomandibular joint and it's infected or inflamed, there will be crepitus, limited range of motion, lots of tenderness and pain. In terms of, I just want to go back again really quickly, in terms of size and shape of the head, you also want to note, does the head size feel appropriate to and proportionate to the rest of the body? When it is abnormally small, we call that microcephaly, and when it's abnormally large, we call this macrocephaly. Now we're going to inspect the face, and mostly we're looking for symmetry and trying to determine if there are any abnormal findings. We're looking for things like coarse features. Exophthalmos, which is this first picture here. Some people call this bug eyes. We see this protruding of the eyeballs. Most of the time, it's associated to hyperthyroidism, so too much thyroid hormone. We're looking for changes in pigmentation of the skin. We're looking for any lesions, scars, any visible masses. We are looking for discoloration like jaundice or cyanosis, pallor, or even erythema. We're looking for edema or swelling. You can see here that this edema, specifically around the eyes or the orbits, we call this periorbital edema, and sometimes you can see that it extends to the cheeks as well. And you see this type of edema where the subcutaneous tissue is relatively loose. You want to note any weird tics or movements, any fasciculations or excessive blinking, and if there's any grinding of the jaws. You're also looking, if you're, just glancing at the eyes, is there any nystagmus? And nystagmus is where you see some oscillating of the eye itself. You can also tell a lot by a person's face when you're inspecting their expression and their facial expressions, going back to that ABCT and general assessment. You can note hostility, aggression, what their overall mood and affect is. So, see if they're tense, are their muscles very rigid, and this could indicate that they're in pain. It could indicate that they're anxious, or if they have a flat affect, so no facial expression at all, and it's not following your conversation or the topic, then this would be called a flat affect. Some things to think about in terms of facial expressions or asymmetric facial findings, which would be abnormal. If there is something that's very markedly asymmetric, this could be a symptom of a brain lesion or even a stroke. Or it could be that your cranial nerve 7, which is your facial nerve, is damaged. So in terms of symmetry, you will see lots of asymmetry. And this can be very severe or it can be very subtle. The damage of cranial nerve 7 is called Bell's palsy. Many times, looking at a patient that may have Bell's palsy, at first glance, if you didn't know the whole story and the whole history, it may look like they have one-sided weakness of their face, and many times people will get that confused with a brain lesion or a stroke. Moving on to the neck, you're going to inspect and palpate again for symmetry. You are going to palpate the lymph nodes, and so you want to go back to the slides earlier and start, with the preauricular or postauricular and move down through those lymph nodes. You're going to palpate the trachea, making sure that it's midline, there's no masses, there's no lesions, and you're going to palpate around the thyroid gland to make sure that, again, there's no masses or lesions. Many people in healthcare think that true palpation of that thyroid gland is more of an advanced technique. However, palpating your fingers all around that area is not a advanced technique. Being able to just feel if there's any lumps, tenderness, or swelling. And lastly, you're checking the range of motion of that neck. And we will go through and you can see the different methods for doing that. So again, looking for symmetry, making sure that the head is positioned centered and midline, and you want to line that up to the trachea, and you're lining that up to the sternal notch. And all the accessory muscles, the neck muscles, they should be symmetric on each side as well. Also note, can the person hold their head erect and still? Range of motion, you want to note any limitation of motion. If they cannot move their neck, or if they've kind of pinched a nerve, so to speak, and they have limited range of motion, usually that person will move their entire body instead of their neck. When you're examining, the neck should be supple. It shouldn't feel like it's sunken in. The motion should be smooth and very coordinated. What we are testing now when we're checking the range of motion of the neck and then additionally the shoulder movement, because remember that neck muscle connects from the bottom of our skull, the bottom of our jaw, going to our clavicle and shoulder area. We're testing the muscle strength and the status of cranial nerve 11. And we will not only just test range of motion there, but the way we check for muscle strength is we're actually going to put pressure on their shoulder and have them move their shoulders up and down against the resistance of your hand. So just like a shoulder shrug, but now your hands are on their shoulders, putting that resistance. You do the same thing with their head movement. Usually I ask my patient to move their head from side to side, look right and then look left. That's range of motion. And now I'm going to have them do the same thing, but I'm putting my palm of my hand on their cheek and having them move into that hand and see if they can press, with strength towards my hand. And I do that on the right and the left. We're looking for the swelling below the angle of the jawline. We're noting thyroid gland enlargement and again, for masses on the thyroid gland. We're going to check for any obvious pulsations. If you were just doing a neck exam, you can check the carotid arteries here too. You should be able to feel a brisk pulsation just below the angle of the jaw when we're checking the carotids. Normally, there are no other pulsations that should be felt when the person is in a sitting position. When you're going through your lymph nodes, this slide is really important for you to understand because we want to know the difference between something that is normally felt and not normally felt. If you feel a lymph node that is freely movable, discrete, soft, and non-tender, this is a normal lymph node. Sometimes you can't feel them at all, but if you do, this is what they should feel like. If the nodes are palpable, whether it's normal or not, you want to note the location, the size, the shape, and you want to note, are they discrete or are they matted together? The mobility of that lymph node, the consistency, and the tenderness. However, if the node is enlarged or tender, you want to check the drainage pattern, and you're checking areas that may drain into that source so that you can think about what the problem may be. Usually it's often related to some type of inflammation, infection, or neoplasm on the head or the neck. In this case, you would follow up, refer your findings to the healthcare provider. If you are the healthcare provider, you need to refer to a specialist. You're checking, if there is an enlarged lymph node, particularly when you can't find the source of the problem, this is even more critical because it could be that there is an underlying neoplasm as opposed to just an enlarged lymph node because you had a cold last week or you had dental work previous day. This slide demonstrates the progression of lymph node assessment. You always start with preauricular, move to postauricular to occipital. Most people then move to submental to submandibular to jugular-digastric. But if you decide to go jugular-digastric, submandibular, submental, that's fine as well. But it is a good progression the way it's shown here. Whatever you do, you want to continue doing it the same way because you don't want to miss any of the regions. But we always start 1, 2, and 3. In lab, I will ask you to be verbalizing all the names. So you have to be able to name these lymph node regions and use the proper technique. So you will be using a gentle circular motion of your finger pads and you're palpating each lymph node area. Okay, remember there's grouping of lymph nodes and you will move your fingers across and lift them up and move them to the next site and use that gentle circular motion. Again, many times I see students and providers demonstrating a pulsating movement of their fingers or tapping movement. And you don't want to do that. You want to make sure that's circular motion. Many times these nodes are closely packed together, so be very systematic so that when you're going through the examination, you do not miss one. Now, I do want to point out that there are some common clues to help you to understand if it's a normal lymph node or not a normal lymph node. And we talked about in that last slide some basic clues, but some other additional things I want to talk about. Usually lymphadenopathy, which means enlargement of a lymph node, if it's over a centimeter from infection, allergy, or neoplasm, we can still, might have a little bit of tenderness, but we can most often figure out the drainage pattern from like an infection or an allergy. Oftentimes with the neoplasm, though, we can't identify the drainage pattern, and that is the big problem where we want to refer. But other cases, especially those that have some chronic inflammation from a disease like tuberculosis, for example, the nodes feel very clumped together. Versus with acute affection, so something that's happened, under 2 weeks, the nodes are going to be bilateral, they're going to be enlarged, warm, tender, firm, but they're freely movable. Cancerous nodes feel like rock hard, and they're usually over 3 centimeters, and usually we only find them unilaterally. They're not tender, they're matted, and they are fixed to adjacent structures. With HIV infection, lymph nodes that you might palpate will be enlarged, firm, non-tender, and mobile. And the occipital node enlargement is very common with HIV infection. Now, if you find a single enlarged, non-tender node that's hard left of the supraclavicular node, this can indicate a thoracic or abdominal type of cancer. We call this Virchow's node or Virchow's node. It's spelled V-I-R-C-H-O-W. Lymph nodes that are associated with Hodgkin's lymphoma, which are very commonly found in that cervical region around the neck, they're painless, rubbery, they're discrete nodes, and they gradually appear as Hodgkin's lymphoma is diagnosed. Now we're going to move on to the trachea. It should be normal, midline, and you should palpate it for any tracheal deviation or tracheal shift. And we talked about in the respiratory presentation that this could be a sign of pneumothorax. If there is a tumor or other type of mass in that area, you might also see where the trachea may be pushed to one side or the other. The trachea is often pulled toward the affected or the disease side when you have atelectasis, large atelectasis, pleural adhesions, or fibrosis. When the trachea is pushed to the unaffected side, we usually see this with aortic aneurysm, tumor, unilateral thyroid enlargement, and again, going back to pneumothorax, it's usually being pushed to the unaffected side, away from the pneumo. A tracheal tug, this is a rhythmic downward pull. It's synchronous with systole, and it occurs when there is an aortic arch aneurysm. Now, I'm not going to test you on that, but I do want you to be familiar with what the tracheal tug is. When you are examining your patient, you want to make sure that you are checking symmetrically the spaces through the trachea, and you want to note any deviation from midline. With the thyroid gland, you're palpating for enlargement, any obvious nodules, you're checking for consistency and symmetry. The only time that you would auscultate a thyroid is if it felt enlarged. And the reason you're going to auscultate with the bell of your stethoscope is because you are checking for the presence of a bruit. And again, this is an accelerated or very turbulent blood flow, whooshing sound, and it may indicate hyperplasia of the thyroid or, hyperthyroidism, which is causing the hyperplasia of the tissues. I want you just to be able to palpate around the thyroid, but you don't necessarily need to do the advanced techniques, which I'm going to show you on the next slide, just so that you understand what they are. You could take a posterior approach, shown this slide here. You stand behind the patient and you're pushing towards that hyoid bone, or you can take an anterior approach, and this time instead of using your fingers, you're using your thumbs. And your left thumb will palpate while your right thumb will do the displacing. One more time, the only time you would auscultate a thyroid for a bruit is if there was enlargement. This is your charting for the week. Subjectively, it says, here there's an example. Patient denies any unusual, frequent, or severe headaches. There has been no history of head trauma, dizziness, or syncope. There's no neck pain, no limitation of movement, lumps, or swelling. The objective, you want to separate the head, face, and neck. The head is normal cephalic. You can also put atraumatic, meaning there hasn't been any trauma. Sometimes you'll see NCAT as an abbreviation. That just means normal cephalic atraumatic. There's no lumps, no lesions, no tenderness. The face is symmetric with no weakness or drooping. There's no involuntary movements. The neck is supple with full range of motion, or ROM. There's no pain. Symmetric neck with no lymphadenopathy, so there's no lymph nodes. There's no masses. The trachea is midline. The thyroid is not palpable, and there are no bruits. Now, just to drive the point home, though, you wouldn't even have to put no bruits. If the thyroid is not palpable, means it's not enlarged, you would not have had to listen for the bruit anyways.